I'd like to introduce our final speaker, Professor Antonio Verdejo Garcia. Myself and Murat met Antonio in Barcelona at an imaging conference, addiction conference in 2008, and through our powers of persuasion and his poor self-control, he now finds himself here in Melbourne, where we've managed to poach him to be part of Monash University. He's a social professor in the same school as Murat. Antonio is also an honorary appointment here at Turning Point. We're delighted and works very closely with Vic. Antonio focuses on the cognitive and the neuromechanisms underpinning executive control and decision-making and their implications for addiction treatment. He's widely published, and his research has been continuously funded via national and international competitive research schemes since 2009. And he sits on the editorial board of a number of key addiction journals. And Antonio is going to talk to us about drug addiction, neuroadaptations, decision-making, and treatment decisions. Welcome, Antonio.
Thank you very much, Dan, for the very nice introduction. I've always done my research in clinical services, or mostly in clinical services. And probably one of the main questions, or the most frequent question that I got from clients or patients, or however you want to call them, is, Antonio, what's going on in my brain? I know I do some weird things from time to time, and I think it's because I took a lot of drugs. I guess my research has been kind of fueled by trying to answering that question. So when you try to formulate the same question from a researcher's point of view, what comes out is something like this. What are the harmful effects of drug use in the brain? And if you want to make the question a little bit more specific, maybe you want to ask yourself, what are these harmful effects of drug use versus pre-existing or learning-related brain alterations that are not directly linked to the neuroadaptive effects of drug use. So that's the question that we ask ourselves for some time. The way we went about it, and that is what I'm going to show you in this study, is we compared people with stimulant use disorder according to the current definition, so something similar to stimulant dependence in the DSM-4. In this case, the study was done in Europe, and the main problem that we have in Europe with stimulants is related to cocaine, so they were mostly cocaine users. And what we did was comparing these people with stimulant-related problems with people with gambling disorder. And the reason for that, you probably figured out already, is that stimulant addiction and gambling disorder are going to share a number of characteristics, are going to share a number of vulnerability pathways, premorbid characteristics, and I'm going to share as well a lot of reward-related experiences. So both populations go through a very intense history of reward and loss. But at the same time, and critically for the design of the study, gambling disorder, people with gambling disorder are free or are not exposed to the exogenous consumption of a substance, and therefore to the drug-induced harmful effects of those substances in the brain. Of course, like cocaine is not the only drug that each of those groups use, like you have some consumption of alcohol and tobacco. So what we try to do is control those by design or by statistical analysis. So this is the design of the study. These are the participants that took part in the study. So they had to be between 18 and 45 years old. The reason for that is, sorry to tell you, but after 45 there's some natural cognitive decline and brain decline, so that is why you have to, this is sobering. The other one is that people had to meet the DSM-TR criteria for either cocaine dependence, that was the old formulation of cocaine use disorder, or pathological gambling, or healthy comparison in the case of people that didn't have any problems, so healthy controls. They also had to be free of other comorbidities, and those comorbidities include medical problems, including neurological disorders or infections, and also mental health problems, with the only exception of alcohol abuse, but not dependence. So they could use alcohol to the extent of abuse it, but not having a diagnosis of alcohol dependence. For those of you that are thinking that this is probably a quite artificial sample, it is. If you want more naturalistic samples, I also have some things for you, but not today. So the idea is to have sufficient control as to answer the question of what were the specific effects of stimulants versus a behavioral addiction. And the other thing is that we had to test participants under a state of sobriety, so they had to be abstinent for more than 15 days. And we did different type of measurements with these sample, but the one I'm going to be talking about today is this measure of brain imaging, functional connectivity. So one of the great things about speaking last is that you don't have to explain many things, which is great for me. So essentially what we were interested in analyzing the connectivity stemming from the, is there any light coming from there? Here you go. The connectivity is stemming from the striatum, and for those that have paid attention to the previous presentations, which I assume is most of you, the striatum is one of the key regions for the pathophysiology of addiction, and a very important region in terms of processing reward and punishment and learning experiences. And what we wanted to do, we wanted to interrogate the connectivity, so the spontaneous communication between the striatum and other regions of the brain, particularly the prefrontal cortex, because we know from neuroanatomical, neurofunctional studies that there are a lot of well-established networks between the striatum and the prefrontal cortex. And based on theory as well, we were interested in discriminating two different networks that are functionally segregated. One network is dependent on or is related to the connectivity of the ventral part of the striatum, or the anterior part of the striatum. For example, the nucleus accumbens, which is one of the key regions in addiction theory, is located here. And on the other hand, we wanted to interrogate as well the network of the dorsal striatum, which is the posterior area of the striatum. And you can see these are the brain maps that stem from doing that type of connectivity analysis. So essentially what we do is we put people into the scanner and we tell them not to think in anything. So what do you think it happens? Well, they think about different things. But through that mind-wandering experience, we can actually identify reliable networks that normally communicate with each other. So you can see, for example, that the ventral striatum network is much more anterior, much more medial, and the dorsal striatum network is much more posterior and more lateral. So essentially, we could discriminate those two networks, but the main point of interest was to tease apart what were the harmful effects of cocaine or of stimulants in general compared to gambling disorder. And we found that there were 3 different circuitries that were significantly strengthened, or more wired, in the case of cocaine users versus pathological gamblers. 2 of them are connections between the ventral striatum and the prefrontal cortex, so the ventromedial prefrontal cortex in the case of the ventral caudate, and the dorsomedial prefrontal cortex in the case of the ventral putamen, and the connection between the dorsal putamen and the insula. The insula is a very important region for interoception, which is the perception of internal signals. So today there's been a lot of presentations around cues that you find in the environment, like, for example, like the sign of the pub on a Friday night, but the insula is not worried about that. Is more worried about things like, for example, an increase in your heartbeat that has been identified through learning experience with the experience of taking a drug. So those can be very powerful cues as well. But I guess the important thing was to understand whether any of these neuroadaptations or any of these altered connections between the striatum and the prefrontal cortex were clinically meaningful. So what we did was trying to connect these, or try to use these baseline images to predict relapse in the long term. So we asked these guys to come back to the lab 3 months afterwards, and we saw that specifically the connection between the ventral striatum and the ventromedial prefrontal cortex made people more vulnerable to relapse in the long term. So why is this connection particularly important? Well, it is very important because it's one of the key brain systems for decision making. So this is the best I could draw a brain in 2009, and I can tell you that I haven't improved since then, but essentially what we formulated in this theory was a neuroscience model to try to explain why people with substance addiction have a lot of decision-making problems. The way we have tested these is through a number of neurocognitive measures, neurocognitive tests. So this is the one that we have used more often, but not the only one. It's a very interesting one because essentially it puts the individual in the position of having to make a number of choices between decks of cards. And the difference between the decks of cards is that some of the decks are really risky, really disadvantageous, because they give you a lot of strong rewards in the short term, but they also give you a lot of punishment or a lot of loss of money in the long term. And on the other hand, you have these other two decks that are relatively safe because they give you little money, but they also take little money from you. So based on these and other versions of the IO gambling task, we were able to profile a cohort of cocaine users into 3 different subgroups. So there was these subgroups that was perfectly okay. They had intact decision-making, so they were fine. Even though they had taken a lot of drugs, they were still fine in terms of decision-making. Then you had a lot of another subgroup that was having some decision-making deficits that were essentially characterized by hypersensitivity to reward or hypersensitivity to punishment, so problems in managing reward and punishment. And then we had a third group that was insensitive to future consequences. So essentially they have some problems to anticipate what was going to happen in the future, and therefore the decisions were entirely based on the short-term outcomes and not at all in the long-term outcomes. And then what we did was trying to quantify relapse in an objective, quantitative way. So the way we did it was through hair analysis. So with hair analysis, essentially what we do is we ask people to come back to the clinic or to the lab 3 months afterwards. And if you have a client like Kate Moss, I wish, then you can analyze, 9 months of drug use because she has a very long hair. If you have someone like me, then you cannot do a lot and you have to use the plan B or even the plan C if necessary. But in the end, what you get is that every centimeter of hair gives you information about 1 month of drug use. And just to help you, although the plot is very self-explanatory, but I used a color code. So here what you see is that the people that had intact decision-making, most of them after 3 months were clear, were abstinent. The people that had some problems with sensitivity to reward or punishment, they had a significant likelihood of having relapsed after 3 months. But the main problem was about the people that had insensitivity to future consequences. And 90% of those people, when they came back to the lab, they had traces of cocaine in their hair. So in essence, decision-making is a very powerful tool to predict what's going to happen in terms of clinical outcome in the future. So obviously one question is whether this is something that these crazy Spaniards found and that's everything, or whether it is a robust finding. So what we did recently is we did a systematic review of the literature linking executive function measures with clinical outcome, so essentially with treatment retention and adherence and drug relapse. We were able to identify 46 studies with different methodologies, and there was a lot of heterogeneity in those methodologies, but essentially all of them were examining the link between executive functions and addiction treatment outcomes. And we found 2 main things. One is that decision-making is consistently linked to drug relapse along those 46 studies, or most of them. And the other thing is that, and this is quite interesting as well for those of you that are working in clinical services, general executive functioning, so not any specific ability, but general executive functioning was associated with treatment adherence, so that people that have lower executive function abilities are less likely to stay in treatment and to get benefit from treatment sessions. So that gave us confidence that this is something that it is worth investigating and applying in clinical and public health imenvironments. Implications from this type of work for both clinical and public health. I guess one of the implications is whether you can apply some of these ideas of personalized medicine to the context of addiction. So in other words, can you use decision-making measures, for example, to generate stratification algorithms that tell you which treatment is best for which individual? And one clear implication of our work is that, for example, people with severe decision-making deficits, they're going to require more intensive interventions, like, for example, therapeutic communities. And actually, in one study that was done in the UK, this connection between decision-making and relapse was buffered by a therapeutic community treatment. So in people that went through therapeutic community treatment, that link was not existent anymore. I know this is not great news for politicians that hate therapeutic communities because they are very, very expensive, but it's something that could be interesting to explore. And on the other hand, like people that have intact decision-making could actually benefit from self-help or very brief interventions. So there is potential of using that information to tailor treatments to people. The other option is to try to generate and to apply cognitive enhancement or cognitive remediation interventions. So Vic told you a lot about this, so I'm not going to insist on that, but essentially there is a number of approaches. I'll give you an example in a minute of things that you can do to try to restore decision-making. Some stuff is coming from cognitive neuroscience, but there are also a lot of stuff coming from law and from economics in terms of modifying decision-making processes that can be relevant in this area. And the other thing is to what extent these tools can be useful outside the lab and can actually be used to implement in public health intervention or population-based assessments. So to give you an example of each of those, in terms of using stratification algorithms, I guess like at this point, we have the knowledge as to being able to generate a neuropsychological assessment that is specific for addiction populations. One of the main problems that we have had in terms of the application of neuropsych tools into addiction settings is that those tools were not thought originally to be applied in addiction settings. They were thought to be applied in dementia settings or in other type of neurological disorder settings. And it took something like 50 years to calibrate and to improve those tools to make them relevant to dementia or to epilepsy. So it's probably going to take some time to calibrate these measures to make them suitable. I hope it's not 50 years. Murat is going to make it quicker. But it's going to take some time to calibrate these measures. But at least by now we know what are the domains that we have to focus on to try to develop those stratification algorithms to improve treatment prediction and treatment action. There are available interventions to improve decision-making in addiction. So we have tried a couple of times goal management training to try to improve decision-making in people with cocaine addiction, polysubstance problems. I don't know how they are called anymore, but people who take a lot of drugs. And in both cases, goal management training, which is a cognitive enhancement intervention that essentially does two things. It helps people to maintain goals in mind effectively. So for example, if someone has the goal of abstinence, it helps them to maintain that goal of abstinence always online, always active. And the other thing that it tries to rewire is the affective tagging that you assign to those goals, such that the affective tagging that you place into the abstinent goal is competitive with the affective tag that you put to having a sip of alcohol or having a line of cocaine. So that's the idea behind goal management training, has been used successfully in our studies. The other idea is to try to interface what we are doing at the level of cognitive neuroscience or clinical neuroscience with public health, and we're doing some stuff around this. One of the things that have been raised before is that there is only 20% of people who go to treatment. So how neuroscience measures and how neuroscience methods are going to be relevant to the other 80%. Well, the only way to make them relevant is to develop tools that are applicable outside the laboratory setting. So we're working with that. We're working with Turning Point in developing an Eastern Health in developing an online battery that is able to assess and quantify impulsivity and decision-making through the internet in just 20 minutes. if we're lucky. And we are developing, for example, tools to try to track decision-making abilities, not only for the individual, but also for interpersonal relationships. So if you have poor decision-making, probably you're going to be more likely to be aggressive to other people, because it's not only about processing rewards and punishment for yourself, but also in an interactive manner. So we're working with people from the Barnett Institute to try to understand how decision-making can be relevant, for example, to predict methamphetamine-related aggression. So, yeah, I think that was it. I think I've been very efficient, but that is thanks to the other speakers that had done everything before. The other thing that I would say is that I haven't thanked all the people that have been involved in this research, but you can imagine that I haven't done it on my own. So there is a lot of people, both here in Melbourne and back in Spain, that have been involved in these studies, and I would like to acknowledge them. And thank you very much for attending. It's great to see this audience for an addiction event. So thank you very much.
So thanks, Antonio. Time for questions. That's right. So while we enjoy a photo opportunity, any other questions?
I'm just curious.
Can I cover it, man?
Yeah. I'm just curious that given the aging population actually around the world, I mean, are there any studies actually going on with the older brain, with the older population, to actually, I mean, being that they'll be presenting to treatments more and more?
Yeah, well, it's an excellent question. I'm sorry to disappoint you. Like most of the neuroscience research is done in young people, and even though, like, I mean, like for example, I know some work done in Cambridge in the UK, linking, let's say, or using some kind of statistical method to calculate how drug use accelerates the aging process. If you're interested in that study, I can find it for you, but I would say it's the only one that has been done in that space. So it's definitely a super interesting area, but not a lot of research done in that. And probably it's just like, it's because like, obviously the incidence of drug use is much more important in young people than it is in elderly people. Yeah, you disagree with that, I know. It's because of how it is measured.
We might call it there, Antonio. Thanks again very much. Please welcome Antonio.